I want to thank the organizers of AIDS 2020 for inviting me to speak about biomedical prevention. I'm going to be talking about moving beyond daily oral PrEP. So, who needs HIV prevention? Well, we have to recognize that key populations now make up more than half of all new infections globally. That means we need to address HIV prevention needs for all of these populations. We'll come back to this point at the end of this talk. Let's start by talking about daily oral PrEP. The first PrEP trials used TDF-based regimens. You can see from this graph that randomized placebo-controlled trials in men who have sex with men, people who inject drugs, and serodiscordant couples all saw a substantial decline in HIV incidence in comparing the placebo arm to the TDF-based PrEP arm. And if you look at subsamples who were highly adherent, HIV incidence was essentially zero, showing the very high effectiveness of these TDF-based regimens against HIV acquisition. The DISCOVER trial tested a second daily oral PrEP agent, tenofovir alafenamide with FTC or FTAF, compared with FTDF in 5,400 men who have sex with men and transgender women, although transgender women only made up about 1% of the trial population. These results were initially presented at CROI 2019 and updated with week 96 data at CROI 2020. These are data from the CROI 2020 update, in which you can see that at week 96, there were 8 infections in the FTAF arm and 15 infections in the FTDF arm. On the right-hand side of this graph, you can see that FTAF was shown to be non-inferior to FTDF. This year's presentation also reviewed safety data through week 96. There were some differences in bone mineral density and renal function that favored FTAF, with a 1 to 2% difference in bone mineral density at the spine and hip, but no difference in fractures, and a 4 milliliter per minute difference in estimated GFR. On the other hand, there were some minor differences in lipids and body weight, favoring FTDF, with a small improvement in total cholesterol, but no difference in the total cholesterol to HDL ratio, and a 1 kilogram difference in body weight. My colleague Julia Marcus created this infographic showing the head-to-head comparison of FTDF and FTAF. You can see that the pills are different sizes. While both drugs are effective for men who have sex with men and transgender women, FTDF is the only drug that's been shown to be effective for heterosexuals and people who inject drugs. There's a small benefit in renal function and bone mineral density for FTAF, so for people with underlying renal or bone disease, FTAF may be the better option. On the other hand, there's a small benefit in LDL and weight gain with FTDF. One of the biggest differences may be in cost and availability. FTDF is widely approved for PrEP and is available as a generic in many parts of the world, and soon to be available as a generic in the US. FTAF is not widely approved globally for PrEP and is only available as a branded drug. For these reasons, many providers are considering FTDF as the universal PrEP, as it can be used in all populations, and reserve FTAF for those patients with underlying renal or bone disease. So, with 2 excellent options for oral daily PrEP, why do we need anything else? Well, for PrEP to have a population-level impact, it must have broad coverage at the population level, and on the individual level must have high uptake, adherence, and persistence. This map shows PrEP coverage by country as of April 2020. You can see that with 580,000 PrEP starts globally, we're less than 20% of the way to the UNAIDS target of having 3 million people on PrEP globally this year. We also know that uptake, adherence, and persistence remain challenging. The graph on the left of this slide shows PrEP persistence by year in the US, and you can see that each year the lines on the graph are rising, indicating improved PrEP persistence. Nonetheless, as of 2017, only 2/3 of people stayed on PrEP through 6 months after starting PrEP. And we have data from multiple studies suggesting that PrEP persistence is poorer among youth in the US, people of color, women, and in rural areas. In sub-Saharan African women, PrEP persistence is also quite low and somewhat worse in young women. So, why do people who may benefit from PrEP not take up PrEP or stop using it? Well, I divide the most common reasons into 5 major categories: sexual risk perception, access, concerns about medications, stigma, and life events. On the left-hand side of this table are some of the reasons that might occur regardless of PrEP modality, including low self-perceived risk, having a lack of PrEP providers, cost and insurance issues, medical mistrust, and concerns about being labeled high risk. For other types of PrEP, the problem could be alleviated by a different schedule or mode of PrEP delivery. For example, on-demand PrEP might work for someone with infrequent sexual contact. Long-acting PrEP could address the difficulty in adhering to visits and lab schedules required by daily oral PrEP. Some people's concerns about specific side effects may be alleviated by different PrEP modalities. Other non-daily forms of PrEP could address the issue that some people just don't want to take a daily pill. And some of the long-acting injectable or topical modalities could address privacy issues. What we've learned from the contraceptive literature is that choice matters. No one size fits all. In this WHO systematic review, increased choice was associated with increased contraceptive uptake, increased persistence on the chosen method, and better health outcomes. In fact, for each additional method that was available, there was a 12% increase in contraceptive prevalence. Similar to contraceptive needs, different people have different prevention needs at different times. So let's talk about on-demand dosing. The original form of on-demand dosing was non-occupational post-exposure prophylaxis. Most data in support of NPEP comes from observational studies in people and non-human primate challenge data. We know that PEP, when started within 72 hours after a high-risk exposure and continued for 28 days, can provide high levels of protection against HIV acquisition. We also know it is difficult for people to adhere to a full 28-day course, and recently investigators have been testing new single and two-dose regimens to prevent HIV acquisition. But how will we test these new modalities in people when the risk from any one exposure is relatively low, and the number that would be needed to evaluate these shorter regimens in a controlled trial could be astronomically large? Another strategy for on-demand dosing is 2-on-1 PrEP. Now, we call this 2-on-1 because the individual takes one pill 2 to 24 hours prior to sex, one pill 24 hours later, and another pill 24 hours after that. This is the regimen that was used in the IPERGAY trial. The IPERGAY randomized control trial showed an 86% reduction in HIV incidence, and the open-label extension study demonstrated a 97% reduction in HIV acquisition compared with the placebo group. On the basis of these data and demonstration projects, the World Health Organization has endorsed 2-on-1 as an effective prevention strategy. However, this is only recommended for men who have sex with men because this is the only population in which it's been tested, and PK data don't clearly support similar regimens in other populations. Another on-demand approach to PrEP is through the use of rectal douches. We call this a behaviorally congruent approach because many people engaging in anal sex douche before sex, so this could be integrated into routine sexual practice. The left-hand side of this slide shows the high levels of tenofovir present in human colon cells in a clinical trial of a tenofovir rectal douche. The graph on the right shows that in this non-human primate challenge study, a rectal douche was even more protective than oral TDF-based PrEP. Let's turn now to talking about long-acting biomedical approaches. The first successful long-acting biomedical approach to preventing HIV acquisition was voluntary medical male circumcision for cisgender heterosexual men. This slide shows the gradual scale-up of voluntary medical male circumcision in generalized epidemics. The dapivirine vaginal ring was found to reduce HIV incidence by 27 to 31% in the Aspire and Ring studies, but effectiveness was considerably higher when ring use was higher. Some advantages to the vaginal ring are that it's female-controlled and discreet, there's limited systemic absorption if there are concerns about systemic toxicity, and there's no apparent antiretroviral resistance that develops in breakthrough infections. So what does the future hold for vaginal rings? Well, 2 open-label extension studies, the HOPE and DREAM trials, found that dapivirine vaginal ring had 39 to 63% effectiveness. Dapivirine vaginal rings are currently undergoing regulatory review. The next generation vaginal rings could include multiple antiretrovirals to improve upon efficacy. Future rings could include longer durability, requiring less frequent changing of the vaginal rings, and the combination of vaginal rings with hormonal contraception. Cabotegravir long-acting is an analog of dolutegravir, an integrase inhibitor. There have been many non-human primate challenge studies demonstrating high levels of efficacy of cabotegravir long-acting against IV, rectal, vaginal, and penile challenges. However, we have to be aware of the long pharmacokinetic tail of this drug. 76 weeks after the last injection, as expected, none of the men or women had what we consider to be therapeutic drug levels of 4 times the PAIC90. However, by week 76, 13% of the men and 42% of the women still had low levels of cabotegravir circulating in their blood. The concern is that if the drug level isn't high enough to provide protection and breakthrough infections occur, there could be enough drug present to select for integrase inhibitor resistance, which would have a negative impact on the individual's care. There are 2 efficacy trials underway testing long-acting cabotegravir: the HPTN-083 study of men who have sex with men and transgender women globally, and the HPTN-084 study of long-acting cabotegravir in women in sub-Saharan Africa. Each of these 2 sister studies has 3 stages. First, there's an oral run-in period to assess tolerability. This is important because once injected, it's impossible to remove the drug. The second stage includes a loading dose of cabotegravir at 0 and 4 weeks, and then every 8-week injections. Finally, the third stage includes another oral PrEP phase to cover that long pharmacokinetic tail that we just discussed. Both trials are using FTDF as a comparator, and there are 2 bridging studies to adolescents corresponding to each of the trials. The HPTN-083 study presented preliminary data publicly in May of 2020 after the DSMB performed a planned interim analysis. At that time, they stopped the blinded phase of the study because it had met the pre-specified non-inferiority early stopping boundary. The overall incidence in the study was low at less than 1%, and there were fewer infections in the cabotegravir than the FTDF arm. The injection site reactions were higher in the cabotegravir arm, but only 2% discontinued injections for this reason. The final results from this interim analysis will be presented later in the week, and here are some questions we hope will be addressed. First, we'd like to see the final HIV infection rate in each of the study arms and to know whether cabotegravir was superior or non-inferior to FTDF. It will be helpful to know whether there were any differences in subgroups, for example, in transgender women who accounted for 12% of the study population. What was adherence like in the 2 study arms? Why and when did breakthrough infections occur in each of the study arms? Was it during the oral or the injectable phase? Was it due to adherence problems? Or was there transmitted drug resistance? Did drug resistance develop after infection in each of the study arms? And lest we think that all of our persistence problems will be solved by long-acting injectable agents, we turn again to the contraceptive literature. These are data from 1.7 million women, and of those opting for DMPA, only half returned at 3 months for their second injection. So we can expect that long-acting injectable cabotegravir may be an excellent option for some, but not all PrEP users. There are also some logistical challenges to administering so many gluteal injections. For instance, if all 3 million people who are supposed to be on PrEP were to receive bi-monthly injections, that would amount to 18 million injections that would need to be given annually to the target population. Implants are another modality for providing long-acting agents. Because these are devices that are planted under the skin and are relatively small, only highly potent drugs can be used. There are a number of advantages and disadvantages to implantables compared to injectables. Implantables can be removed when needed and have more consistent and predictable drug release, allowing for lower doses of drug per day. They avoid the long PK tail that we saw with long-acting cabotegravir, but rather when they're removed, there's no more drug left. They may remain in place for a year or more, requiring fewer visits, and they have the potential for improved adherence. Disadvantages include that they require special devices and sterile technique to insert. They may require a small surgical procedure to remove unless they're bioerodible, and they have the potential for scarring and migration. Islatravir is a unique, highly potent, long-acting antiretroviral with a novel mechanism of action as a nucleoside reverse transcriptase translocation inhibitor. It has very high potency, a favorable resistance profile, good safety and tolerability in studies to date, an extremely long half-life, and favorable tissue penetration. Islatravir has the properties that enable daily, weekly, monthly, low-dose oral dosing and yearly implantable regimens for both HIV treatment and prevention. This slide shows that the islatravir implant design is similar to the Nexplanon implant. The graph on the bottom right shows data from a presentation at last year's IAS meeting in which islatravir was modeled to provide protection for more than 1 year when delivered as an implant. Let's turn now to talking about HIV vaccines, and I'm going to focus on what we're learning from vaccine efficacy trials. Remember that vaccines are the only modality to eradicate an infectious disease, smallpox. The column on the right of this table also shows the profound impact vaccines have had on the annual number of cases of a variety of other infectious diseases. The only HIV vaccine trial to demonstrate efficacy to date was the RV144 TIE trial that showed 61% vaccine efficacy through 12 months post-enrollment, declining to 31% protection by study end, with vaccine efficacy waning as the immune response in the trial waned. Based on these positive results, the Pox Protein Public-Private Partnership, or P5, was formed to oversee the development of a new Alvac GP120 regimen to increase subtype C coverage, improve antibody durability, and test if the correlative vaccine efficacy seen in the TIE trial, V1-V2 IgG, could be replicated as a correlative risk and vaccine efficacy in this trial. Here is the 702 schema. What's important to note here is that there was a change in the Alvac vaccine which now included a clade C insert, the GP120, which was now a bivalent subtype C subunit protein given along with a different adjuvant, and 2 booster doses given at months 12 and 18 to improve the durability of the vaccine response. Unfortunately, in January 2020, the DSMB conducted an interim efficacy analysis and found that the vaccine provided no protection against HIV acquisition. There are a number of possible explanations for the lack of vaccine efficacy that are currently being explored. The immunogenicity of the vaccine regimens could have been different due to differences in the canary pox insert, the protein, and the adjuvant. The viral genetics could have contributed to the different results, as it's likely that the epidemic in South Africa is considerably more virally diverse than was seen in Thailand during the Thai trial, creating a higher likelihood for the vaccine sequence to be mismatched to the circulating strain. Host genetics or other host factors, including mucosal inflammation and the microbiome, could have been substantially different between the two populations. And the HIV exposure was undoubtedly greater in the HVTN 702 than the Thai trial, with a greater force of infection that may have overwhelmed a moderately protective vaccine. More data addressing these questions will come out in the upcoming months. One of the challenges to developing an effective global vaccine is the genetic diversity of HIV worldwide. Inclusion of mosaic sequences in vaccines can improve overall coverage of global diversity. The Ad26 mosaic vaccine, when given with a GP140 protein boost, is a promising new HIV vaccine candidate. This includes a mosaic insert with broad coverage of circulating strains. In a non-human primate model, it's been shown to provide 94% protection for each rectal challenge and 67% complete protection after 6 challenges. This vaccine regimen also induces a durable immune response, with early-stage clinical trials suggesting higher immune responses in humans than what had been seen in the non-human primate challenge studies, and durable immune responses remaining at high levels for at least 2 years. The Imbokodo and Mosaico trials are sister efficacy trials. Imbokodo is a study in 2,600 women in sub-Saharan Africa that's fully enrolled and in follow-up. The Mosaico trial is a study in 3,800 men and transgender women and men who have sex with men in the Americas and Europe, which is just beginning enrollment. Both studies administer the Ad26 mosaic vaccine at 0 and 3 months, and the Ad26 mosaic with a clade C GP140 at months 6 and 12. The Mosaico trial also includes a mosaic GP140 at those last 2 time points. PrEP is available to all participants in both studies. Now, the PrEP vaccine trial is a combination of PrEP and vaccine trials. It's evaluating PrEP and vaccines in high-risk heterosexuals and men who have sex with men in 4 African countries. The vaccine consists of 2 DNA protein combination regimens versus a placebo control administered over a 12-month time course. What's different about this study design is that the first part of the trial is evaluating FTAF and FTDF in a head-to-head randomized fashion for the first 6 months of the study, while the immunity is being generated by the HIV vaccine. Then, PrEP is withdrawn at 6 months to see the effects of the vaccine. Let's turn now to talking about monoclonal antibodies. There's a long history of using antibodies to prevent viral infections as depicted in this table, and most vaccines that are effective induce antibodies that neutralize the pathogen. This is a schematic of the broadly neutralizing antibody targets, or bNAbs, against HIV, and the various bNAbs directed against each of these targets. The AMP studies are 2 parallel trials, one in 2,700 men who have sex with men and transgender women in North and South America, and the other in 1,900 women in Southern and East Africa. VRC01, a bNAb directed against the CD4 binding site, is administered IV every 8 weeks. The studies are evaluating 2 different doses of bNAbs, followed by monthly HIV testing. Sequencing will be done of breakthrough infections to determine whether they occurred because of a defect in coverage or defect in potency. PrEP is available to all participants who want it, and results are expected later this year. Future bNAb trials will include combinations of bNAbs to achieve broader neutralization coverage. Other developments in bNAbs include longer half-lives and the ability to administer them subcutaneously. And remember, one of the advantages of bNAbs compared to PrEP candidates is that there's no concern about the development of antiretroviral resistance. So this table presents a summary of what we've discussed: daily oral PrEP, on-demand regimens, long-acting PrEP agents, vaccines, and bNAbs, and the different populations in which they've been approved. You can see that all of these key populations have approved daily oral PrEP with 1 or 2 different PrEP agents, and all are eligible to receive PEP after high-risk exposures. Oral 211 PrEP is only available for men who have sex with men. Voluntary medical male circumcision is only available for heterosexual cisgender men. Vaginal rings are under review, and we have brand new data on long-acting cabotegravir for use in men who have sex with men and transgender women. This slide includes the many agents that are currently undergoing testing, and you can see that the table is getting filled in quite nicely. However, heterosexual cisgender men and transgender males have considerably fewer options being currently tested than other groups, and people who inject drugs have no new HIV-specific biomedical approaches being evaluated. In closing, let's briefly discuss the future of HIV prevention trials. Because of the ethical imperative to ensure that all participants have access to highly effective prevention strategies, how will we test new, unproven regimens going forward? Well, there are 3 basic study design structures that can be used. The first is to do a head-to-head comparison of a new PrEP agent against an existing PrEP agent, as was done in the DISCOVER trial and the HPTN 083 and 084 studies. The challenge here is that if low infection rates are seen in both arms, how can you be sure you enrolled a high-incidence population? The second approach is to offer PrEP to all candidates and then layer on top of that background rate of PrEP uptake either the vaccine or bNAb versus a placebo. The challenge here is that if too many participants opt for PrEP, infection rates may be so low in the study overall that you can't test the efficacy of the vaccine or bNAb. The third approach is being used in the PrEPVac trial, in which everyone gets PrEP, but then the vaccine is compared to the placebo. The challenge here is that you can't likely improve upon PrEP by adding to it, so instead PrEP is withdrawn to assess vaccine efficacy. So how do you remove PrEP safely and ethically? In conclusion, people need more options than daily oral PrEP. There are advantages to on-demand products, particularly for less frequent exposures. It would be helpful to have shorter PEP regimens, but they may be difficult to test in human clinical trials. And questions remain about whether there will be a role for mucosally delivered products, which I think could be an important addition to our prevention options. Long-acting agents alleviate some but not all of the adherence issues we see. There are different benefits and downsides to different modes of PrEP administration, and the landscape for testing new products is becoming increasingly complex. We need more strategies for people who inject drugs in particular, but also cis and transgender males. I'd like to close by thanking the people from whom I borrowed slides or who helped me in shaping this talk. Thanks very much.